Hello everyone, I'm Dr. Anupama Chowdhry Devgan, your physiology faculty. We are in week 5, day 4 of our daily quiz series, and this week we are focusing on endocrinology and some miscellaneous topics. So let's have a look at today's questions. Which of the following hormones uses cyclic GMP as a second messenger for its actions in the target cells? Now, this is a very simple question because there is one hormone which uses cyclic GMP, in fact, only one, and that is atrial natriuretic peptide, and of course, brain natriuretic peptide. These use cyclic GMP as the second messenger. Norepinephrine parathormone use cyclic AMP. Thyroid is a lipid-soluble hormone, so it has a nuclear receptor. It does not need any second messenger. Now, this is a very important topic as far as NEETPG is concerned, so let's just go over which are the hormones using cyclic AMP as a second messenger and which ones use phospholipase C, that is inositol triphosphate and diacylglycerol. So what I've done is I've divided hormones into hypothalamic hormones, anterior pituitary, posterior pituitary, and miscellaneous. So remember, hypothalamic hormones use mainly the phospholipase C mechanism except CRH. Remember, C for CRH and C cyclic AMP. Now, all anterior pituitary hormones use cyclic AMP except growth hormone and prolactin. These two do not need a second messenger because they act via the JAK-STAT pathway. Remember, all anterior pituitary hormones use cyclic AMP. There is no anterior pituitary hormone using the phospholipase C mechanism. Now, posterior pituitary hormones, ADH and oxytocin. ADH has 3 receptors, V1, V2, V3. V2 receptor, which is present on the collecting duct, uses cyclic AMP as a second messenger. V1 and V3, these use the phospholipase C mechanism. V1 is mainly present on the blood vessels and V3 on the anterior pituitary. It is responsible for release of ACTH. Now, oxytocin uses the phospholipase C mechanism. Now, there are 2 hormones for glucose metabolism, insulin and glucagon. Insulin does not need a second messenger because insulin receptor itself has tyrosine kinase activity. Glucagon uses cyclic AMP. 2 hormones controlling calcium metabolism, parathormone and calcitonin, both use cyclic AMP. Now, adrenergic receptors can be beta or alpha. Beta 1, beta 2 adrenergic response uses cyclic AMP, which has been asked as a question, and alpha 1 adrenergic response uses the phospholipase C mechanism and also angiotensin 2. So just keep this table in mind. Once you go through this table 2 or 3 times, you'll have a visual impression and it will become easy to answer questions on the second messenger. Now, cyclic GMP, I told you, there is these 2 hormones, atrial natriuretic peptide and brain natriuretic peptide, which use cyclic GMP. The hormones which do not need a second messenger are growth hormone, prolactin, and erythropoietin because they act via the JAK-STAT pathway. And insulin and IGF-1, these also do not need a second messenger because their receptor itself has tyrosine kinase activity. So these are the hormones and their second messenger, including the hormones which do not need a second messenger. I've spoken about lipid-soluble hormones in an earlier video. I told you about lipid-soluble hormones having cytoplasmic receptors or nuclear receptors, which hormones have cytoplasmic and which hormones have nuclear receptors has been already dealt with. Let's see the next question. A birth control pill for men is being developed. Which of the following will provide effective sterility in men? Now, to go over the regulation of testosterone secretion, let's see this diagram, which has been asked as a question in a NEETPG exam earlier. So the GnRH from hypothalamus will act on the anterior pituitary. Anterior pituitary secretes FSH and LH. FSH receptors are on the Sertoli cells. And how do we remember that? S in FSH, S for Sertoli. Sertoli cells secrete inhibin, which has a negative feedback effect on the secretion of FSH. LH receptors are present on the Leydig cells. L for LH, L for Leydig, and Leydig cells secrete testosterone. Testosterone has a negative feedback effect on both the secretion of LH and GnRH. FSH, when you look at spermatogenesis, the last step in spermatogenesis, that is conversion of a spermatid to a mature sperm, is FSH and androgen dependent. All the earlier steps are FSH and androgen independent. Now, let's have a look at the options. It says a compound which mimics the action of LH. If it mimics the action of LH, it will increase the secretion of testosterone. And testosterone is so important, like I told you, in the last stage of spermatogenesis. So this cannot be an answer. We are looking for a drug which provides sterility in men. A compound which mimics the action of GnRH again will cause increased secretion of FSH and LH. FSH will act on Sertoli cells and LH on Leydig cells, more testosterone, spermatogenesis. So this is also not the answer. A compound which blocks the action of inhibin. Inhibin has a negative feedback effect on the secretion of FSH. So if I block inhibin, there is going to be increased secretion of FSH. That will also help in spermatogenesis. A compound which blocks the action of FSH on the Sertoli cells. Remember, the Sertoli cells have a very important supportive role in the spermatogenesis. So if I use a compound which blocks the action of FSH, this will produce an effective sterility. A large dose of insulin is administered to a patient. Which of the following changes is not likely in this patient? By giving a large dose of insulin, you have caused a decrease in the blood glucose level. You have produced a hypoglycemia. Hypoglycemia is a very potent stimulus for the secretion of growth hormone. So definitely growth hormone secretion will increase. It is a very potent stimulus for the release of glucagon. So glucagon levels will also increase. And hypoglycemia is a stressful situation. There will be increase in catecholamines, so increase in epinephrine. But aldosterone will not show an increase. What causes increase in aldosterone is either anything which increases the renin secretion, hypovolemia, hemorrhage, hypotension, hyponatremia. All these will increase renin. Renin will increase the levels of angiotensin 1, and then angiotensin 1 gets converted to angiotensin 2, which increases aldosterone. Aldosterone can also be increased if there is an increase in the plasma potassium levels. These are the two stimuli for increasing aldosterone. Hypoglycemia does not cause an increase in aldosterone. Which of the following causes a decrease in the metabolic rate? Now, fever, exercise, these are definitely associated with increased metabolic rate. Growth hormone is also a catabolic hormone. There will also be an increase in metabolic rate. But malnutrition or starvation causes a decrease in the metabolic rate. Sometimes a decrease may be as much as 30%. This is produced by starvation or malnutrition. Now, this is one diagram which I want you to see. This has been asked as an INI-SET question a few years back. So when you look at the levels of T4, T3 and RT3, what is RT3? Reverse T3. It is physiologically inactive. Now, when I look at this graph, T4 is much more than T3, which is more than RT3. RT3 is the least. It is secreted least by the thyroid gland. Its blood levels are also the least. Now, if you can see, this is the graph for T4, this is for T3, and this is for RT3. Now, I have written that T4 is much more than T3. But when you look at the graph, it doesn't appear so. But that's not true, because the T4 scale is given on the right side. It is in micrograms per deciliter. Whereas the T3 and RT3 scale is given on the left side. That is in nanograms per deciliter. So T4 levels are in micrograms. Therefore, and T3 and RT3 is in nanograms. So T4 is much, much more than T3 and RT3. Now, what I want you to focus on is, during a period of starvation, what do we find? We find that instead of T3 being more than RT3, now T3 levels are dropping and RT3 levels have increased. So during starvation, the reverse happens. RT3 becomes more than T3, but as soon as you start giving normal diet to this individual, the ratios will again go back to normal. But during that period of starvation, RT3 is more than T3. And I've already told you that RT3 is physiologically inactive. So by having RT3 more than T3, it helps to conserve calories. So important in a patient who is already who's already in a calorie deficit. Now, there are some other conditions where RT3 becomes more than T3, and that is in prolonged starvation, in burns, trauma, advanced cancers, cirrhosis, febrile states. When I say febrile states, it means when fever is prolonged. Right? Then RT3 becomes more than T3. But of course, like we've discussed, fever by itself causes an increase in metabolic rate because there is heat being generated. But prolonged fever can give rise to RT3 becoming more than T3. Myocardial infarctions, chronic kidney disease, liver cirrhosis, etc. So any prolonged illness will cause the RT3 to become more than T3. Which of the following would be expected in a patient of 11-beta hydroxylase deficiency? Now, this is extremely important again. There are two important enzyme deficiencies, 21-beta hydroxylase and 11-beta hydroxylase. So let's first have a look at the steps in the synthesis of the adrenal cortical hormones. Now, these are steroids. So they are all synthesized from cholesterol. Cholesterol is converted to pregnenolone, which is converted to progesterone, 11-deoxycorticosterone, corticosterone, and then aldosterone. And pregnenolone can form 17-alpha-hydroxypregnenolone, which is converted to 17-alpha-hydroxyprogesterone, 11-deoxycortisol, and cortisol. And similarly, you've got the synthesis of androgens. Now, let us have a look at the enzyme deficiencies. The first one is 21-beta hydroxylase. 21-beta hydroxylase is converting progesterone to 11-deoxycorticosterone and 17-alpha-hydroxyprogesterone to 11-deoxycortisol. So if there is a deficiency of 21-beta hydroxylase, this step is blocked, and the further steps obviously will not occur. So what will happen to aldosterone levels? Reduces. Cortisol reduces. Androgens will be in excess. These are 21-beta hydroxylase deficiency. These are 95% of patients of congenital adrenal hyperplasia. A reduced aldosterone, reduced cortisol, and excess androgens, which is responsible for the virilizing symptoms. Why is there an adrenal hyperplasia? Because of decreased cortisol, there is going to be increased ACTH, adrenocorticotropic hormone. Adrenocorticotropic hormone will cause growth of the adrenal cortex. So adrenal hyperplasia. So next is 11-beta hydroxylase. So let's see if there is a deficiency of 11-beta hydroxylase, what is going to happen. 11-beta hydroxylase is catalyzing the conversion of 11-deoxycorticosterone to corticosterone-aldosterone and 11-deoxycortisol to cortisol. So again, decreased aldosterone, decreased cortisol, but excess of androgens. But one major difference, 11-deoxycorticosterone is going to be in excess in this patient. What will happen because of that? I will just discuss. So going back to our table here, if there is 11-beta hydroxylase deficiency, this is 5% of patients of congenital adrenal hyperplasia. Similar clinical picture, a decrease in aldosterone, decrease in cortisol, excess androgens, and responsible for virilizing symptoms. Let's have a look at the 17-alpha hydroxylase. Now, 17-alpha hydroxylase catalyzes the conversion of pregnenolone to 17-hydroxypregnenolone, progesterone to 17-alpha hydroxyprogesterone. In other words, 17-alpha hydroxylase is an enzyme which is required both for the synthesis of cortisol and androgens. So if there is a deficiency of 17-alpha hydroxylase, cortisol and androgens are reduced and aldosterone is in excess. Let's look at the 1720 lyase deficiency. Now, 1720 lyase is an enzyme which is required for the synthesis of androgens. So if this step is blocked, there is decreased androgens, excess cortisol, excess of aldosterone. So going back to our table, decreased androgens, increased cortisol, and increased aldosterone. Now, if you look at 21-beta and 11-beta hydroxylase deficiency, they have a similar clinical picture. So let us try and see how are we going to distinguish between 21-beta and 11-beta. In a patient of 11-beta hydroxylase deficiency, 11-deoxycorticosterone. This is absent in 21-beta, but in excess in 11-beta hydroxylase deficiency. Now, 11-decorticosterone itself has mineralocorticoid activity. So, mineralocorticoid activity is present in 11-beta, absent in 21-beta. And what is the role of mineralocorticoids? They cause a sodium retention. Therefore, there is going to be water retention, there is increase in ECF volume, there is increase in blood pressure. So if I measure the blood pressure, I find it is elevated in 11-beta hydroxylase and reduced in 21-beta. Simple test to distinguish between 21-beta and 11-beta. Measure the blood pressure. Elevated in a patient of 11-beta hydroxylase deficiency. Look at the plasma potassium level. What is the role of mineralocorticoids? Sodium absorption, potassium secretion. So plasma potassium levels will be low in 11-beta and elevated in 21-beta. So by doing two simple tests, you can distinguish between 21-beta and 11-beta. Measure the blood pressure, see the plasma potassium levels. Going back to our question, which of the following would be expected in a patient of 11-beta hydroxylase deficiency? Hyperkalemia? No, in fact, we expect a decreased plasma potassium. Increased blood pressure? Definitely. Is there going to be increased plasma renin? Now here, mineralocorticoid activity is already present. So there is sodium and water retention, increase in ECF volume, increase in blood pressure. So in fact, we expect the plasma renin levels to reduce, aldosterone to reduce. Aldosterone will be reduced because it is not being produced here. So this is your questions for today, and that is day 4.